Good evening to everyone, and welcome to our exclusive webinar, ASCO 2024 Highlights, Advances in Melanoma and Related Cancers. I'm Jasmine McGowan, the Managing Director of Save Your Skin Foundation, and tonight we are honored to delve into the latest advancements in melanoma and related cancers with our distinguished speaker, Dr. Omid Hamid, Chief of Research in Immuno-Oncology at the Angeles Clinic and Research Institute. Now, before we begin, let me provide you guys with some context for tonight's session. This webinar is a joint collaboration between Save Your Skin and AMAD Melanoma. Our aim for tonight is to provide you with invaluable insights from leading experts in the field. Dr. Hamid will guide us through the newest findings and treatment options for melanoma, as well as update on non-melanoma, skin cancer, and ocular/uveal melanoma. This is an opportunity not to be missed for anyone passionate about advancing their knowledge in skin cancer and in the melanoma space. Again, I want to thank you all for joining us tonight, and let's get started. So I would like to start off by introducing our incredible speaker today, Dr. Omid Hamid. Dr. Hamid, MD, served as the Chief of the Translational Research and Immuno-Oncology Department at the Angeles Clinic and Research Institute, and he's also known as the Director of the Melanoma and Phase 1 program. He holds the title of Professor in the Department of Medicine at Cedars-Sinai Medical Center. Dr. Hamid has areas of expertise, including immunotherapy and phase 1 drug development. He also earned his medical degree from the University of Southern California, or USC, Keck School of Medicine. He completed his internship and residency at the Los Angeles County Hospital USC Medical Center and conducted his fellowship at the Los Angeles County Hospital and USC Norris Comprehensive Cancer Center. Dr. Hamid is a board-certified medical oncologist, and his research focuses on manipulating a patient's immune system to attack the cancer cells and maintaining a continuous elevated levels of immunity. Dr. Hamid is internationally recognized as a leading immuno-oncologist and melanoma specialist. He has authored numerous publications and has been instrumental in developing groundbreaking therapies, including BRAF/MEK targeted agents, anti-CTLA-4, anti-PD-1, and PD-L1 therapies. His current interests include exploring new immunotherapeutic options such as bispecific antibodies, adoptive T-cell therapy, and I'm sorry if I'm going to butcher this, Oncolytic therapies, with an emphasis on combination approaches to maximizing his patient benefit. Under his leadership, the Angeles Clinic established a program that integrates expert clinical care with teaching and pioneering clinical research. So with that being said, I am going to stop sharing my screen and turn my camera off and allow Dr. Hamid to begin our presentation tonight. Thank you so much, Dr. Hamid.
All right, thank you so much for this lovely introduction and our ability to be part of the review for ASCO 2024. There is a lot to go through, so I will start and go quickly. ASCO 2024 was chock full of information, not just for melanoma, but for other solid tumors. And as we go through this, you'll see how we have improved on what we've known before to be true and where things are going. These are my disclosures. Enjoy those. I couldn't have said it better. It's from comfort to cure. This is Lynn Schuchter, who is a melanoma physician at Penn, who is ASCO president this year. And a lot has happened. So we know checkpoint therapy has changed the outcome of advanced melanoma. We have standard first-line PD-1 based single or combinations. There are newer checkpoints, newer combinations, adoptive T-cell therapies, triplets, quadruplets, adjuvant, neoadjuvant. We'll go through all of it. We'll focus on melanoma, but as you know, the other skin cancers, basal and cutaneous squame, take their cues from melanoma, so this is relatable to that. Most of the data and the trials that you see here can be utilized for those tumors. We'll spend some time on ocular melanoma and brain mets and go forward. Look at this. We pre-1998, no approvals, and now this is Hussein Taubi's slide where he's taken other people's slides and just added on to it 14 approvals since I've been taking care of melanoma in my career, with the approval of lifileucel, TIL therapy, right behind relatlimab, nivolumab, triplet therapy, TVEC, and others. And we're looking forward to making greater strides. As we know, that checkpoint inhibitors are the basis for the therapies for many solid tumors in the teens, but in melanoma, with the approval of CTLA-4, which is a antibody to an inhibitory receptor, PD-1 an antibody to an inhibitory receptor, and LAG-3 an antibody to an inhibitory receptor, we are looking at other antibodies that activate and work towards either putting the foot on the gas on the left side here, as you can see, or taking the foot off the brake on the right side. We realize that these are important at many different times in our T cells journey, and that the inhibitory receptors increase as we become more resistant. So the questions become, should we give them early? Should we give them after a combo has failed, or what? What we have realized, and this is data from Georgina Long and others, and I've shown the same in single agent PD-1, is that the progression-free survival, the amount of time that the drug works, is best when you get a CR. That's those complete responders, that everything goes away or the PET scan is negative. So we're trying to push more people to complete response. The partial responders do a little bit better than the ones in stable disease, but as you can see here, not just in overall response, but in overall survival, we got to get more people to get a complete response or a deep partial response and work on boosting them when we get there. And this is true for even relatlimab, nivolumab, and this was recent data that was presented by Steve Hody and others at the end of last year, and comes through as we have updated this data at ASCO. So that's progression. What we really have seen, and this is also Hody, what we have really seen from 067 is this is the progression-free survival on the bottom left-hand side, that we get about 30, mid 30% of patients who don't progress on therapy at 3 years. And I will put your focus here at 3 years, where you see these curves. Initially, 100% of people have not progressed, but then they start to progress and the numbers get less, and less. But look at what happens at 3 years. That's the plateau. And that's what I tell people. Let's work to getting you to that 3 years, because lots of great things happen at 3 years. If you have not progressed at 3 years, your overall survival is high. It's in the 90s. Your progression-free survival on PD-1 is in the 90s. Your melanoma-specific survival, that means death to melanoma, is in the high 90s. So we got to get people to have a good response and keep that. And at 3 years, that's the magic thing. And we're trying to figure out what's best. Is it Ipi-Nivo from Checkmate 67, or Rela-Nivo, which is the LAG-3, or is it a single agent PD-1? We're comparing them here without real signals. What is the next thing we're going to do? And here's the next thing. Paulo Escierto, who you've heard a lot about, and these are our brethren, not in Canada and not in the States, but in ex-US, Paulo Escierto in Italy, Reinhard Dimmer there in Switzerland, Georgina Long in Australia. We got an American site here that snuck in. That's Evan Lipson, who you've known, who's in Hopkins. And they did this, Relativity 48. You'll see Relativity 47 was Rela, the LAG-3, and Nivo, the PD-1. Relativity 48 looked to improving what we've seen before. These are the progression-free survival and the overall survivals from Ipi-Nivo. Look at the 3-year overall survivals, and you can see here again in overall survival, the plateau at 3 years. I'll be talking about that a lot. And Rela-Nivo, the same thing. You start to see at 3 years a plateau around 50% and a plateau of progression around 30% in both of them. But where are we going? And this was what we saw in Relativity 48. and that is a triplet. Remember, I told you we'll be talking about triplets, nivolumab, relatlimab, and ipilimumab. We saw that this triplet, now that's not a lot of patients, okay? 46 patients. Remember, these trials are in the 300s in each arm, but this is an early trial, 46 patients, and you can see the progression-free survival at 3 years is 50%, not in the 30s, in the 50s. And this is what gives us hope. The overall survivals at 3 and 4 years in the 70s. Now, it's 1/10 of the patients, but still a wonderful indicator that one, we can safely give these drugs together. And even if you run into toxicity, in these patients who discontinued due to toxicity, they did not progress at 3 years past. This is PFS, progression-free survival. Not only can we give them, we can give them without significant toxicity, and we can benefit patients. And so where is this going? We still have to figure out what is happening here. The response rates are high. They're similar to what Ipi-Nivo showed, not increased complete response rates. So we're still looking to see what's going on. Here are the overall response rates in Ipi-Nivo, 58%, Rela-Nivo, 44%. Here's the triplet, 58%. That's 46 patients. I'll talk to you about TIL and pembrolizumab, 65%, and TIL in first line, 49%. So there's a lot going on here, which we need to tease out, increase response numbers and complete response. So we've got combinations in first line. We're trying to tease out who benefits from what, and we're trying to decrease the toxicities. And the grade 3 to 4 treatment-related toxicities, and as you'll remember in baseline with a PD-1 is all, those are the toxicities that really need attention. In just PD-1 alone, they're about 11%. In Ipi-Nivo, 59%. That's why we had some concerns. In Rela-Nivo, 21% less, and in Ipi-Nivo-Rela, 39%. But we are getting numbers that are very interesting, and hopefully will continue as we increase the accruals to these trials. We're still looking for predictors of response. LAG3 expression didn't look good in relativity in Rela-Nivo, and still does not look like a promising thing. If you're not expressing high levels of lag, basing a protocol on LAG3 therapies. So do we use this in the clinic? No, but indicators of what we're trying to find. What also happens is what we've known is these combinations may not be great after you have failed a first-line therapy, either single agent or combination with PD-1. And I take you back, this is Paulo Ascierto's data from 6 years ago, and this is the early relativity trial in second line. So what we're really learning is you got to put all your gusto in the first line and second line, try to find novel targets. We've looked at certain things, and this is data from Steve Hody, Jeff Weber, and others, that IL-6, which is an inflammatory marker, is a prognosis for people who do poorer, the red line, as far as overall survival, even in single agent PD-1, Ipi-Nivo, PD-1 CTLA-4, or CTLA-4 alone. So what we have done is considered adding an IL-6 inhibitor to these drugs. So this is Ipi-Nivo and an IL-6 inhibitor. And this is a drug that we use to decrease inflammation. We used it during COVID to decrease COVID inflammation. And there are multiple trials, including one we did with Jeffrey Weber, where we saw less toxicity. This is one done Adi Diab at MD Anderson. And not only did they see that they got higher response rates, but they also got increased immune cell trafficking. Now, this is a big scientific poster, but those are the things where we want better response rates, and probably we want to bring more T cells in, so those patients who don't respond just to checkpoint inhibitors can respond better. And so we've taken this further. This is a trial that's accruing here at the Angeles Clinic at NYU, at Mass General and Dana-Farber, and it is that triplet along with an IL-6 inhibitor. And we're going to see what that adds because it's going to go into a randomized fashion of triplet versus triplet plus IL-6 inhibitor. So far, very interesting. Look forward to it. We're also looking to find better ways to give anti-CTLA-4, which you're familiar with, which is Yervoy. Here's data, and I'd like to say that I was part of this, but I'd like to also tell you that Paulo Ascierto, this name that you hear all the time, has led it. And this was randomized between low dose and high dose ipilimumab way, way, way back when. This was published in 2017. That's the Stone Age, but you can see here in overall survival, getting higher doses of ipilimumab led to a better long-term survival, and that plateau at 3 years is higher. Same thing with the other CTLA-4 inhibitor that we don't use as much. So there are new drugs, and this is a bioAtla drug that we are utilizing now in combination with nivolumab. It is called a conditionally active drug that only becomes active in an acidic environment, which is the tumor. In a normal cell environment, it does not become active. So it does not cause side effects or toxicity, whereas a normal CTLA-4 can be active and inflame a normal cell. And what we've done here is this is a trial that is now in the first line, and we're accruing to a dose which is similar to 10 milligrams along with nivolumab. So we're trying to get these two drugs together so that we can get better benefit. We're also looking at newer LAG-3s and PD-1 combinations, and this I presented at ASCO last year, and is a major randomized first-line trial where we've seen higher response rates, albeit in 100 patients, but an overall response rate of 61% and a benefit of 80%, which looks on par with Ipi-Nivo and the triplet. Well, should immunotherapy be used earlier? This was answered a long time ago. That's a couple of years ago in randomized fashion, showing that immunotherapy in BRAF mutant patients should be the first line therapy unless they are symptomatic. Overall response and survival are improved when you start with immunotherapy, although there is this subset that needs an extra oomph. And that has ended up being what has plagued us. We don't really know who those people are. We do know, and this is from dabrafenib plus trametinib, if you can get them to a complete response, their overall survival is better. And this mimics what I've shown you before. And with immunotherapy, but with targeted therapy, this is BRAF and MEK, we see the same thing. So for all our patients, we're learning, get them to better, deeper, longer benefits, and we're working on that. But this was a trial presented by Carolina Robert, and she is in Paris. And you'll see the final author, Alexander Van Apoy, who is in Australia. And this was basically a trial of saying, hey, how about we give a little bit of BRAF inhibitor followed by ipi-nivolumab versus just starting with ipilimumab, nivolumab? What's better in a whole host of patients? And we found that the induction with BRAF and MEK is not better. Boy, this is a busy, busy, busy slide, but there are a lot more progressive events, and in the purple shows in the brain. And really, this said that beginning with BRAF inhibitors for all comers is never the right thing. We're still trying to find those people. So we've had 3 trials showing that immunotherapy first line is the best thing. This is the one I just showed you, 270 patients. You can see higher overall survivals, higher 2-year progression-free survivals. Succumbent looked at just giving 2 months of BRAF MEK and going to Ipi-Nivo versus starting with Ipi-Nivo. Everything trended, in the favor of Ipi-Nivo first. You could give 2 months. This is arm C. and it looks similar, but we still don't know who those patients are. Those of us who take care of melanoma think it's those with a significant burden of disease, requiring steroids, having pain, and needing a rushed response. And so that's what we've learned. We're still working on second-line therapies. This shows response rates in second-line therapies in melanoma, where TIL looks to be great. If you have not seen anti-CTLA-4 in the first line, you need to see it in the second line if possible. And now we're looking for other information, okay? This was presented at ASCO. I believe Meredith McKean did this, where we're looking at other therapies. So this I put up where you say, hey, I'm a patient, I'm looking, what should we look for? Well, other checkpoint inhibitors, TIL therapies, and we'll talk about the lifilocell updates and Obsidian TIL, TCR engineered T cells are coming in melanoma, immune therapies, including cytokines, there's IL-2, antibody drug conjugates, which target specific proteins in a tumor, or targeted therapies based on mutations, including BRAF mutation drugs where you failed, or things that target BRAF and NRAS moving forward. What about other immunotherapies? I presented the update in the ImmTAC, brenetafusp, and ImmTACs. I don't know if you're familiar with it. You should be. But let me introduce another investigator, Diwakar Davar, who is wonderful at the University of Pittsburgh Medical Center. Some of you will say, well, Pittsburgh, we know that place. Jason Luke is there and others, but super interesting is an ImmTAC is an immune mobilizing, is an immune mobilizing drug that targets the T cell receptor. And it works sort of like this. You give the drug, it targets a protein that's expressed by the tumor. It also targets, on the other side, CD3 on the T cells. It helps T cells traffic to the tumor. Brenetafusp targets PRAME, which is expressed in 90% of tumors of melanoma, of cutaneous melanoma. This looks familiar because these are the drugs. This is the same backbone for Kimmtrak or tebentafusp, which is approved in metastatic uveal melanoma. We've shown that that drug, the tebentafusp, Kimmtrak, is tolerable with anti-CTLA-4 and anti-PD-1. And now we have a drug, PRAME, that targets 90% of cutaneous melanomas. The main thing is you need to do a blood test to see if you're HLA-A2 positive. This is how it works. You put it in, it targets the cancer cell protein that is expressed by HLA-A201. That's why we do the blood test. It then brings the anti-CD3 cells in. It creates a connection. It's a matchmaker, bad matchmaker, where the T cells become activated and they kill the tumor. So we know that it increases interferon, so that's markers of inflammation that help increase PD-1 expression, so it may work better with a PD-1 inhibitor. And we know that if you do blood tests, 24 hours later, those lymphocytes, those T cells, are not in the blood. They're trafficking to the tumor, as you can see here on biopsy. So that's great. And we showed that this drug has a great response rate. It's about 11%, but it really works by controlling disease. It has a 60% disease control rate. And it is now, it can be combined with nivolumab and a PD-1 inhibitor safely and showing activity. So there's a first-line trial here. Oops, this is not the slide I wanted. Let's go back one. There's a first-line trial here of brenetafusp and nivolumab versus nivolumab alone outside the US, but versus relatlimab, nivolumab, LAG-3 PD-1 in the United States. So we're looking to actively accrue and see if this really works better. Why would it work better? Because we have some patients who don't respond to checkpoint inhibitors, and we think they're refractory because you don't have enough T cells there. Guess what? This brings the T cells in. We're also looking at this drug, the Kimmtrak drug, in second-line patients that are cutaneous, acral, or mucosal melanoma. And we're randomizing in second line to physician's choice, Kimmtrak alone, or Kimmtrak plus an anti-PD-1 agent. So this is another ImmTAC that targets GP100. What about oncolytics? We used to hear a lot about TVEC. We don't hear much about TVEC anymore. But what you hear about now is the Replimune drug, RP1, RP2. We'll talk about RP1. It's an oncolytic immunotherapy. It's a herpes virus that's been changed. You inject it into tumor, it causes an immune response, brings T cells in, and those can go other places. And at ASCO, data was presented on it as far as RP1. RP1 has a GM-CSF, which was also in TVEC, but it's an immune activator. RP2, the second generation, has an anti-CTLA-4 antibody. Where have we heard that before? Ipilimumab, etc. And then there's an RP3 coming, which has more things packed into the virus. But this was data that was presented by Michael K. Wong. Mike Wong is at the University of Texas MD Anderson Cancer Center. Why am I telling you about all these investigators? Because they're wonderful. And they're really working hard to figure it out. Mike Wong is at MD Anderson with a lot of other people, but I'll point out that they're Gino In, who's at USC, Kathy Tsai, who is at UCSF, Celeste Labe, who's in France, and I'll do a shout out to Bartosz Chmiełowski at UCLA, and Mohammed Milham, who's at the University of Iowa. This was injected in patients in the second line who had failed anti-PD-1 therapy, and we saw good duration of benefit. These are the swimmer's plot. The longer it's out there, the better the patients are doing, the longer they're staying on. These are spider plots on the bottom left, and you can see here the tumor volumes just coming down and staying down. So we've seen patients have response in injected and non-injected lesions. You can see here the yellow, so let's go to the bottom right. Injection into the scalp showed the resolution of lesions in the liver and non-injected areas in some patients. And guess what? This is one of the first oncolytics in melanoma where we have shown not only the ability to indicate injection into under skin or in lymph nodes, but safe injection into viscera, that means organs like the liver, with responses in the liver and the injected and non-injected lesions and durable benefit. And this is now becoming a randomized trial in the second line. It's called Ignite-3, and it will look at second line therapy versus RP1 and a PD-1 inhibitor. What about other targeted therapies? Man, I got a lot of slides to go through, so we'll go a little faster. We're about halfway through. These are antibody drug conjugates. They have an antibody that targets a protein on a tumor, and at the back, there's a drug, which is usually chemotherapy. And guess what? These work. They're like sending a Molotov cocktail in a Trojan horse. They bind, they go into the tumor, the chemotherapy is released, and we've seen DYP668 presented by Matteo Carlino. He's in Australia at the Melanoma Institute of Australia. Show this drug, show responses in uveal melanoma by targeting GP100. And there were some skin melanomas on there. We have yet to see what's going on there. These antibody drug conjugates can enhance anti-tumor immunity because they cause the cells to die. They can also bring T cells into the tumor microenvironment. And there are other targets that are expressed in other cancers, but are also expressed in melanoma, where we're looking to get our patients. HER3 is expressed in breast cancer, but also in melanoma. So we can use these drugs for our patients. There are antibody drug conjugates now, and this is a drug by Molecular Therapeutics that are engineered toxin bodies. MT8421 is is an ADC that targets CTLA4. So it can work with immunotherapy. But let's skip and talk about what everyone is so interested in these days, and that's tumor infiltrating lymphocyte therapy. You can see here we take a part of the tumor. We take a tumor out through a surgical procedure. We digest it, and we take all those T cells here that are targeting proteins directly on the tumor, not just one protein, multiple proteins. And we take those T cells, we expand them in a lab to billions and billions of cells, and those come packaged. The patient takes about 3 weeks to manufacture that. A week before that drug is done and being delivered, the patient gets admitted and gets chemotherapy, not to target the tumor, but to get rid of the other T cells in the patient. And then that patient, is infused with the TIL, those tumor infiltrating lymphocytes. Those should traffic into the tumor area, and then we agitate them by giving high-dose IL-2. And in the past, this has been shown to give benefit to a subgroup of patients. The problem was making the TIL, and what we have now are multiple companies who will take your tumor, make the TIL, ship it back to you, and that's what Lifileucel did, and this is through Iovance. We saw in heavily pretreated patients, the majority had 3 lines of therapy. The majority had also already seen anti-PD-1 and anti-CTLA-4. We had patients with 7 to 10 lines of therapy. We showed a response rate of 31.4% with a durable response. Good Lord, take a look at this. We're getting around 3 years, and we're seeing a plateau there. So now this is approved in the States as a second-line therapy. The slides I didn't put up here is that in the Netherlands, John Hannon, who's at the Netherlands Cancer Institute, did a second-line trial versus ipilimumab and showed that TIL was better, and that led to its approval in the Netherlands. So we're finding out that TIL works. It may work better earlier, and it may work better even before you see anything. This was presented by Sajeev Thomas, a good friend who's at the Orlando Health Cancer Institute. And this was a first-line trial that was global, because you can see the second investigator is this lovely investigator, Dr. Helen Gogas, who is in Athens, Greece. But this said, what if we did TIL plus PD-1 in immune checkpoint inhibitor naive patients, those who had not even seen PD-1 or CTLA-4. And at ASCO, the update was presented here. The response rate was 65.2%. The complete response rate was 30%. And the disease control rate was significantly high. It was over 90%. Now, this is only 23 patients. It's early, but what we saw was early control and long-term durable control. You can see someone out 45 months here. And we saw that there's some indicator that you can look at the blood and look at the T cell receptor clonotypes, so what the TIL is targeting. And if it shares that between tumor and the TIL product, you get a longer benefit and you respond. And if it doesn't, you don't. We know that this is helpful because these TIL that you infuse remain in the body for extended periods of time. Then Rodabe Amaria presented what may be the next generation of what's going on here. And this was a single institute trial of a drug that's now being looked at in many institutes, including mine. This is OBX115. And this is a TIL therapy that doesn't need interleukin-2 because it expresses interleukin-15, which we think is a more tolerable interleukin. And the people you see here, Jennifer McQuaid, who's at, they're all at MD Anderson. They're all melanoma people, and they work really hard understanding not just TIL, but Jennifer McQuaid looks at diet in melanoma. Michael Davies, brain mets. Elizabeth Gletza, you'll remember, are the people who were working on our behalf to look at what you call it, melanoma that's gone to the leptomeningeal area, so leptomeningeal disease. Hussein Taubi, who's there, Michael Long, and others, Patel Adidia. And this is the TIL. Cytotil has a TIL expansion, but it has a druggable area here that when you give an exogenous drug orally, releases, good Lord, releases interleukin-15. And we find that possibly interleukin-15 can drive NK cell expansion, which IL-2 doesn't do well, and it doesn't increase Tregs or cause capillary leak, some of the toxicities. So we're looking at that. These patients get manufactured, they get the lymphodepletion, they get the infusion, and then they get the drug, acetazolamide. It's an oral drug. It's not interleukin-2. And what happens is this causes IL-15 to be expressed. They don't need to be in the hospital to get infusion. And the other thing is those TILs remain. So at any time, you can reinduce those TILs with just giving an oral drug. And so what they saw was a response in patients who had seen multiple prior lines of therapy and BRAF inhibitors. And this is going further. What about those patients here who are saying, well, what about mucosal melanoma and other melanomas? Well, these TILs are being looked at in ocular melanoma and have shown response. This is the data from Iovance that was presented in Madrid at ESMO, that even in mucosal melanomas, only 12 patients, you saw a 50% response rate. So open to all. As we're coming through an end, let's talk about adjuvant therapy in melanoma. Is this now still the standard of care? Well, yes. In stage 2 patients and stage 3 patients, multiple trials, just nivolumab or KEYNOTE-54 pembrolizumab showed an improvement in relapse-free survival. We're awaiting the overall survival data, but this has become standard. In fact, in the adjuvant, in patients who had areas of metastatic disease, we went in and took them out. This is Dirk Schadendorf from Germany's data, Immunet study. It showed that you can give checkpoint inhibitors and whether it's Nivo, Ipi, Nivo, and you could do better than just giving nothing. And in a stepwise fashion, you can see here overall survival curves. As you go further and further out, the Ipi-Nivo combination in the metastatic setting looks better than just the Nivo, and you're starting to see plateau. So here's what we're learning, 3 years. So in 2024, we're seeing that in BRAF mutant patients, you can give dabrafenib plus trametinib and improve relapse-free survival, just like you can give pembrolizumab, just like you can give nivolumab, and you can get 5-year relapse-free survivals around 50%. It's better. What about long-term follow-up? And this is the longest term follow-up. This was presented not by Axel Hochschild in Germany. There's Reinhard Dimmer again. but by Georgina Long in Melanoma Institute of Australia. And she showed 10-year data, 10-year data. This was published in the New England Journal, that what happens is as you get to 3 years, remember, adjuvant therapy is only 1 year of therapy. You get this benefit, and that benefit is quick. Benefit is better than placebo, and that benefit remains. So as you get to 3 to 5 years, you're getting that plateau. That's wonderful. What is more important to me is distant metastases-free survival. That means recurrence outside of the local area. If you had something on the arm, recurrence outside of the local area, and that benefit remains at 10 years, and overall survival benefit remains. So adjuvant therapy looks good, because if you get it, here are these people who have options should they recur, but there is more and more of a difference. Now, this was not a significant difference, but it's showing a trend towards it. What we've also heard is how can we improve adjuvant therapy? And this is the Moderna trial. You've heard about this vaccine, Moderna vaccine. You take some of the tissue, you make a 34 neoantigen vaccine that targets 34 proteins on the tumor. And this was the 3-year follow-up of a trial of pembrolizumab, which is Keytruda, versus the vaccine versus pembrolizumab alone. Keynote 942 presented by my good friend, mentor, and the guy who runs NYU, Jeffrey Weber. And what he showed here is a sustained improvement in relapse-free survival as we go further and further along, which is significant. And if you look at this, the relapse-free survival with pembrolizumab is similar to what we've seen in other trials. So there's a bump, and that bump, that difference remains. And distant metastases for survival benefit is there. It's significant and it remains. But this is only 100 versus 50 patients. There is a major randomized trial of vaccine plus pembrolizumab versus pembrolizumab, which is accruing nationwide, will end accrual in by the end of the year. We look forward to further data. We also found that biomarkers like looking at circulating tumor DNA can tell you who is going to do poorly. And we have some indication to that. HLA diversity also. But the main stuff that came out in melanoma was, what about those people that have bulky disease? Should we give them immunotherapy first, do surgery, finish out a year of therapy, or should we just do the surgery and give them the single agent PD-1? This was a trial done by Christian Blanc. We'll talk a little bit about that. We've looked at neoadjuvant trials, and we found that either it's IO immunotherapy or targeted therapy, you've got to get the tumors to a complete response at surgical time, and you can get better benefits. So this gentleman sitting next to me is Christian Blanc at the Netherlands Cancer Institute, where John Hannon is. And he did this wonderful trial. He presented it. It was a plenary, so one of the top 5 things that was presented. Christian Blanc, there's Georgina Long again, Richard Scollier. And we were part of this, thankfully. But this is neoadjuvant ipilimumab nivolumab versus adjuvant nivolumab. In macroscopic, that means the lymph nodes you can feel or see on a scan. This was a randomized phase 3 trial of hundreds of patients. And it was between giving a couple doses, then doing surgery and finishing out, versus just doing adjuvant. And just to go quickly, the event-free survival, the recurrence, was significantly benefited by giving some combo immuno first. And this is becoming a standard now in those people who have big palpable nodes that you can feel or see on imaging. Not only that, but if you went further, it worked in BRAF mutant and BRAF non-mutant patients similarly. And this is the pathological response. The green line up there is if you gave 2 doses and you had everything go away once you did the surgery, you looked in, it was all gone away. You did well. 95% of people did not recur. In fact, if you had a path complete response that after 2 doses, you stopped, you saw that there was no more viable tumor, you didn't give any further therapy. And guess what? 60% of the patients treated that way had a complete response and never needed further therapy. So what are we doing? We're identifying those people who do really well, who don't need a year of therapy, and you can protect them from the side effects of therapy also. So it was a checkpoint inhibitor, neoadjuvant phase 3 trial, and it showed that ipi-nivo is a highly statistical significant event-free survival. And 60% of patients in the neoadjuvant arm only needed 6 weeks of treatment. You don't need to come to see me for a year or 2 years, etc. And all subgroups benefited. Paulo Asierto presented, what about giving in BRAF mutant patients treatment with BRAF inhibitors and then PD-1. This was Neotim, and it didn't show any benefit. So the idea of adding to targeted therapies in the neoadjuvant setting is sort of going out. We're looking at other combinations in stage 2, just to point out, high recurrence rates. So PD-1 alone is the standard at this point. How can we figure out who does well or not? There was the MelaRisk profile presented by Teresa Amaral, and Teresa is, sorry. Teresa is in Germany, and she looked at this is a test that is not clinically available right now, but it identifies people at high risk. And you can tell now those people, even with a stage 1B, so that's, a tumor that's, ulcerated under 1 millimeter or near 1 millimeter, or 2A. These are people who we don't give adjuvant therapy for. You can identify a very poor survival subgroup. You can see here in 10 years, they have a 20% mortality. And there is an ongoing trial led by Dirk Schandorf where you take these poor prognosis patients and give them adjuvant PD-1 and see if it works, if giving PD-1 versus placebo. So we're trying to help a broader range of patients and keep patients who don't need it away from therapy. How about in stage 3, if you're doing well? This was presented by the Melanoma Institute of Australia, but also Sao Paulo, looking at PET scan to tell you if you're really getting a great response. So we may even be able to know from PET scanning. This is very early, but I thought it was one of the most interesting posters presented. And I'm close to running over, but also I'm close to being done. Brain mets. We know that ipi-nivo is the standard. Trials that are coming forward will probably add to that with a huge response. This is what we've known, but you have long overall survivals. Look at 3 years, you're plateauing. 75% people at 1.5 years in patients who had a poor response. So I went and said, hey, can I figure out more? Well, this was Rela-nivo versus nivolumab trial in the first line, and it showed, guess what? That the number of events, the number of brain mets decreases if you give Rela-nivo versus nivo. And at 2 to 3 years, it's only about 6%. That's great. You're doing much better. So guess what? This is indicating that we have other regimens to look at and maybe triplets. Succumbent, which I talked about, also shows that, the brain mets survival in the long term is better if you start with immunotherapy. So this is more agents that are the more data to say that first line should be immunotherapy. This came from Mike Postow, whose name you hear a lot. He's the head of the melanoma division at Memorial Sloan Kettering Cancer Center, and Sarah Loughran from his site. A lot of data here, but this says that if you have anti-PD-1 therapy and you have melanoma brain mets, going just to ipi-nivo is not going to control it as well as you could. So we need to look for other options in second and third line. So not a lot about brain mets, but guess what? As I end, I want to talk about uveal melanoma. There is great data that's coming forth. This was presented by Anthony Joshua, who is in St. Vincent's Hospital in Sydney. And this was in localized uveal melanomas, and I'm losing my voice, I'm sorry. Looking at patients who don't have metastatic disease, but have a big, huge ocular melanoma, where it affects their vision, where if you chose therapy, the right therapy is either radiation or enucleation. And you said, what can we do? We found that there are mutations in that those tumors, and we treated with darvacertib as a targeted agent, just a single agent, and we saw a high response rate with just 6 months of therapy, that we could decrease the tumor. And if you look at the bottom left, pre-therapy, you had a big lesion, you could shrink that lesion and therefore radiate less and prevent enucleation or loss of vision. And in 75% of patients, you preserved the eye. You could treat with radiation. Only a quarter of those patients needed to go to enucleation. So that's a great thing. We look forward to long-term data showing that in relation to recurrence and survival, this is a safe thing to do. It's important because darvacertib is being looked at in combination with crizotinib, 2 targeted agents in HLA-A2 melanomas, the HLA-A2 negative melanomas, those that cannot get tebentafusp in the metastatic setting in a randomized fashion. I told you I would talk about how oncolytics work in uveal melanoma, but this is a drug from Replimune. This is RP2. Remember, we talked about RP1, oncolytic herpetic virus, and it can be injected, as you can see in the bottom left, into the tumor, into the liver multiple times, and get great stable disease and great control. And at ASCO, Joe Sacco presented this. Joe Sacco is from the University of Liverpool. And we showed, or they showed, as monotherapy or combined with PD-1, you can get a durable response rate, 30%, and disease control, 60% for an extended period of time, only in 17 patients. This will go into a major phase 3 trial in the upcoming months. What I bring your attention to is the bottom, injecting into that red area with evidence of other areas in the liver, the yellow circles. You can see just by continued injection into the red area, the yellow areas began to resolve, and so the uninjected lesions respond. So I hold a lot of hope for this, a lot of promise. What else do we have? TIL therapies for uveal melanoma, um, antibody drug conjugates that target GP100, um, tebentafusp combinations, as we talked about. See, this is what I was talking about. And so uveal melanoma, a lot going on. So as I come to the end and put up my information there and end right on time, surprisingly, I would say to you that I showed you a lot of stuff here. And the reason I showed it to you is to say, one, we're working hard trying to find answers. Two, there are drug companies, pharmaceutical partners that are stepping forward and really contributing with drugs that can help us answer those things. Three, there are so many different programs, not just one place can have it. Here at the Angeles Clinic and Research Institute, Cedars-Sinai affiliate, we have a whole host of them. But I've introduced you to significant contributors at other agencies and other institutes that you may want to reach out to in the future. I'd like to end by saying that my personal collaboration with AIM at Melanoma and Save Your Skin goes back a long, long time. And I'm very happy that they're there, not only helping us with advocacy, but also helping with education and what I think is the most important thing, patient navigation. So please, if you haven't already, go to these websites, look at the whole host of support that they offer. If you talk to patients or physicians, please send them to these sites. These are sites that have been vetted. These are sites that support investigators and all of this work that's being shown here. And with that, I want to thank everyone for coming, and we'll give you the rest of your evening back.
Thank you so much, Dr. Amy. That was an incredible presentation. And like you said, a lot of information that you got from ASCO. I was hoping though, would you be available to answer maybe 2 to 3 questions that we did have come in?
Sure.
Fantastic. So I'll just start with the first one that someone asked here. What was the toxicity from the use of the triplet?
Well, the toxicity from the use of the triplet, I would say the most important thing is that it was not novel, which means we didn't see any toxicity that we hadn't seen before. No toxicities that we hadn't seen before. They were manageable, and they make it so that we will be comfortable if this comes forward.
Wonderful. One more question here. Is there any evidence yet for a 3-year stable platform in OM?
Well, I don't think that we can say that there's any of that at this point. And the reason being is that these agents are novel and new in OM. But yes, the overall 3-year updates with tebentafusp don't show that type of plateau, but do show a long-term benefit. So I would hesitate to use that convention in uveal melanoma at this point.
Okay. And back to OM, one more question here. What is being done to prevent METs after ocular melanoma is stabilized? Do you have an answer for that?
Sorry, say again, what is the
What is being done to prevent METs after ocular melanoma is stabilized? So,
So you're talking about adjuvant trials in uveal melanoma, and we still haven't found one that works. I did not present the adjuvant trial of Ipi-Nivo that was presented, and that was promising. We don't know where that's going to go forth, but it's still not a standard.
okay. And I'll ask you just one more question here. For a BRAF positive stage 4 patient that reoccurs, what is the advised order of therapy? What place do BRAF/MEK inhibitors have for these patients?
Well, I think they have a lot of place, but usually what we look to do is push off BRAF therapy and look at giving earlier therapies that are, you haven't seen CTLA-4, if you haven't seen TIL, any clinical trial that's interesting, and then go to the BRAF therapies.
Fantastic. Well, I think we'll end it there for the questions. Again, I just
I
want to
got
thank.
one more.
Oh, we do. Yes. Sorry.
Yeah, I'll answer.
Yeah.
What if you're HLA-A2 negative? So I talked about the idea trial of darovasertib and crizotinib versus investigator's choice. So if you're first line, go for that trial. If not, go for other clinical trials. Till we have a novel ipilimumab, nivolumab, and tumor treatment fields trial here. We have some certain phase 1 trials that are looking to target, pathways in uveal melanoma. We haven't talked about the approval of Heptazo for liver-only disease, but I would say uveal melanoma, look for centers of excellence.
Thank you so much. Okay, I'm just going to put my screen back up. I want to thank you again so much for bringing your wealth of knowledge to this call and presenting everything to us today. Um, as we conclude our webinar, I just want to thank you once more for sharing your time. And I also want to thank the audience for joining us for this hour and taking an hour out of your evenings to join us. I would like to remind everyone that this webinar is going to be accessible on the Save Your Skin website and our YouTube channel, as well as AIM's website and their channels as well. This recording is available on demand for those that have registered, so you will receive an email from Zoom regarding that. But we will be sending out an email from both of us just letting you know when it is available for you to watch whenever you would like. I want to thank you all again for attending this evening, and I wish you all an incredible night, and I hope to see you again. Both of our Save Your Skin website and AIM at Melanoma's website is on the screen right now. Dr. Hamid, 1,000 times thank you, and I hope you all have a lovely evening. Thank you so much, everybody.